مع نفسك. Medical management of GERD. Everyday story. Everyday story, you know, you understand everyday story. It's everyday story. شهرزاد شهريار حدوتة ألف ليلة وليلة. This is the book of GIT. هنفتحه. We will open it and we will find that this book has the GERD. أول صفحة كده. You open the book تلاقي الجيرد قدامك. First GERD. This is a 118 years old story. من زمان خالص. Before China. GERD then China. راجل اسمه تايلستون ده 1906 قال بيبتيك ألسر اوف اسوفيجس. في انكلستين سنة 34 سماها بيبتيك اوسوفاجيتس. أليسون this is different from ليفربول. ده أليسون مش بتاع ليفربول، ده الثاني he is injured مصاب ما بيلعبش دلوقتي. سنة 46 first one discovered hiatus hernia. The one that Dr. Gina said and Dr. Shaimat said that you cannot say that there is hiatus hernia. After that, the first thing to describe non-erosive gastroesophageal reflux disease, GERD, it was in the year 1958. And after that, by the 80s, they started to show the relaxations and contractions. If we don't have this, we don't have the lecture of Dr. Gina. And we don't invite her. And she will stay at home. Okay. What about the management? The management is actually what we don't do. That's why patients, they do not improve. Because according to the guidelines, we skip 2 pages and you start with the things that we do. Because management is about lifestyle. Who of us spends time with his patient to tell him what to do and what not to do? Nothing. The best of us gives a paper written to the patient to read at home, having some instructions. This patient, after he exits your clinic, he will use this paper to press the button of the elevator. And after that, to erase his hand from the dirt, from the bottom of the elevator. And before leaving the building of your clinic, he will throw this paper in the garbage can. You don't speak with your patient, he will not follow your instructions. So, what about the lifestyle modifications, which are the best medical treatment for GERD? Somebody like that, he must lose weight. Yes, according to the guidelines, the strength of scientific evidence and the pathophysiology may be not that very conclusive, but it is highly recommended. What about this meal? We are hungry. All of us need this meal. كلنا جعانين عايزين ناكل الأكلة دي. Unfortunately, fatty meals, they cause GERD. So, it's recommended not to eat fatty meals. What about returning 12 o'clock from the clinic? You are hungry. Late evening meals. Who can fight late evening meals? Nobody can fight late evening meals. But they are pathophysiologically conclusive of causing GERD, and we must stop late evening meals. What about even the speed of eating? The speed of eating itself triggers GERD and increases GERD. You have, after 2 minutes, you have to leave because you have an endoscopy in Maadi. After 15 minutes, you have another endoscopy in 6th of October. And after that, you have to catch your plane because you are invited by Zahir to Lebanon and you want to not to miss this trip to Lebanon. I have not been invited to China, so I will not speak about that. Okay, this is the strength of evidence is high and its recommendation is yes. Of course, now we are boycotting all this but this is also very harmful, so we have to boycott it because of another thing, that they have to trigger GERD, so it's recommended not to use carbonated beverages. What about citrus? Citrus is a little bit conditional. If it hurts you, don't use it. If it doesn't hurt you, then take it. What about now? When I go with my wife to the cafe, I don't know what she is actually drinking. Because she asks for a flat white, decaffeinated, de-skimmed, I don't know what is this. I ask all coffee, please. Some nicotine, caffeine, IV. And I understood why she is hurting more than me. Because this is harmful. These things we go to the cafe and drink, it is harmful. It causes, and you should stop it. What about alcohols? Of course, alcohol is a little bit a point of debate because some authors, they say that it does not affect, some say it's affect. It's not generally recommended to stop alcohol, but we put it into the recommendations. What about smoking? If I see this picture, of course, I will go for smoking. I suggest smoking. I think smoking is nice. But of course, we know in life, anything that looks nice is actually bad. Yes? Yes. So, it is recommended not to smoke. حلو الإنجليزي ده يا عامر؟ حلو؟ تسلم. Heavy exercises. Heavy exercises. Let's all do heavy exercises. Heavy exercises are not recommended and they increase GERD. So, light exercises, yes. Like watching TV, very nice. Pressing on the button of the remote is a very heavy exercise for us. Not more than that. Don't go to the gym because it will increase gastroesophageal reflux disease. So, what about head elevation? Head elevation is recommended. It puts the esophagus away from your stomach in a different level. So it is recommended, and that's why marketing, they made what's called GERD pillow. And they only not made that. As you can see, they made a tunnel. Why is this tunnel? They tunnel to put your left hand in it so that you can sleep on your left side. Similar to the sleep of singles. He will embrace the pillow. He does not have a wife. He does not have a companion. So you do that, you don't get GERD. So being married and having a woman with you, it will increase the GERD. It is not recommended in recommendations, but this is Naguib's recommendation. Okay, so these are the lifestyle, and this is summary of the recommendations. What about medications? We have plenty of medications, of course. It was the first H2 receptor antagonist, and they say that it can work on the pain receptors, so people who are having non-cardiac chest pain, they might benefit from something like the H2 receptor antagonist. But the big problem about H2 receptor antagonists, that they have something called tachyphylaxis. You can use them for 7 days, 10 days, not more than that. You will lose the benefit. That's why it can be only used in very, very limited situations, like part of step-down treatment, nocturnal acid breakthrough, add-on therapy, or for rapid relief of symptoms, or what's called on-demand therapy. This is the only rule for H2 receptor antagonist nowadays. Gina, she mentioned something very nice, transient lower esophageal relaxations. And she said that if we control this, this might help us with the reflux episodes. We have a very nice drug called Lioresal, or what's known in market as Baclofen. It controls these transient lower esophageal relaxations. It should be very nice and very good home for gastroesophageal acid reflux patients, but unfortunately, its side effects makes you prefer gastroesophageal reflux disease than being treated with the Lioresal, because it causes drowsiness, dizziness, weakness, tiredness, headache, tribals. It's very, very intolerable drug, in fact, even if you use it in a very little amount. There are some adjunct therapies like antacids, aluminium, calcium, magnesium. They have rapid relief. Sucralfate, which plays a good role in pregnant population especially, and some new bioadhesives containing hyaluronic acid and chondroitin sulfate. Of course, also the use of alginate, it can act on the acid pocket, which is present in the fundus by making some coat for it. And of course, prokinetics, they don't have an actual role unless that we have some problem with gastric emptying. You have to prove that there is a problem with your gastric emptying first, and you have something called gastroparesis, and after that it would be beneficial. Otherwise, it has no role in gastroesophageal reflux disease because they do not work on the esophagus. They do not work on the esophageal motility. They work only on gastric. Of course, we have the two important classes, proton pump inhibitors, and of course the recent one that came from Far East, which is the PCAPs. And of course, we know about the mode of action that they have. And we have 7 proton pump inhibitors. They are known in the market now. And actually, despite all the meetings that they put some differences between the different PPIs, meta-analysis, and all the researchers, they say that they have the same effect. They have no actual true differences between them. So if you like the purple one, use the purple ones. If you like the blue ones, use the blue ones. If you like the red ones, use the red ones. Don't give me a headache. Okay? Some unmet needs with the proton pump inhibitors made us look for something newer than that, which is, of course, the PCAPs, which started to be used by the year 2015. And we know about its dynamics now, that the potassium competes with the hydrogen to enter the cell and prevents the hydrochloric acid from being generated and liberated. And this is a way of acid suppression without affecting the proton pump itself, and these are the differences that you know it better than I do. What about the last part of my lecture, which is the prescription? Gina helped me a lot, that she showed the algorithm to deal with a patient with classic or typical symptoms of gastroesophageal reflux. She was marketing for pH monitoring and impedance. I am marketing for the prescription that me, myself, as a clinician, will write to my patient. So, same algorithm, we have 3 cases, 3 conditions: classic GERD, extraesophageal GERD, and refractory GERD. For the classic GERD, this is the one that Gina actually mentioned. Patients who are having the typical symptoms, you will have the 8-week PPI trial, and we will wait to see if there is complete resolution of the symptoms or not. If complete resolution, you will discontinue the DPPI and you will watch for the results, what's going to happen. If they have incomplete relief, then you will start to investigate furtherly after stopping by 2 to 4 weeks, and you do the endoscopy. If you find documentation of gastroesophageal reflux disease by being class B, C, or D Los Angeles classification, this is a confirmed case of GERD. If not, then you will call Dr. Gina and you will start the monitoring and so on. So this is the first one. Of course, these are the mimickers of gastroesophageal reflux. We will not go through them. Dr. Gina already mentioned them, like motor and esophagitis and the gastroparesis and the rumination disorders. The lecture is not about that, but about just to tell you that there are mimickers at that place. You have to search for them, and you will start searching by the pH monitoring and the impedance Dr. Gina just mentioned in her lecture. The second part is the extraesophageal GERD, which is the presence of extraesophageal symptoms. You have to take detailed history, and you use your companion, the specialist in the other specialty. You have to discuss the case with him very well. And if typical GERD symptoms associated with extraesophageal symptoms, then you will try the PPI up to 12 weeks, or of course the PCAPs. If the symptoms improve, so it is more suggestion of being GERD. If no improvement, then go back to square Gina. If not, if extraesophageal symptoms only, then you have to go to Gina directly before you start doing something else. If it is abnormal reflux monitoring, then treat as GERD. If it is normal, then consider other things. What about optimizing PPI? Before speaking about my last prescription, which is the refractory GERD. Before condemning the patient with this diagnosis of refractory GERD, you have to make sure that the PPI is optimized. Optimization is by verifying compliance, that the patient is really taking the drug every day. Confirm that it is taken 30 to 60 minutes before meals. You have to spend some time asking the patient and investigating why he is not improving on the medications you have written. You might escalate the drug dose up to twice daily dosing per day, or maximizing the dose before condemning the patient by the diagnosis of refractory GERD. So the refractory GERD has one or two conditions. The first condition, that you started by empirical therapy, and the second condition, that you have an objective confirmation by an endoscopy or pH monitoring that this is a case of gastroesophageal reflux. According to that, you will optimize the treatment of PPI and you will do the approach. And according to the results of the pH monitoring, you will start to discuss with the patient the further management approaches, like, for example, the sphincter augmentation, or the endoscopic or the surgical approaches, like the next lecture, of course, we will discuss with you. So in a nutshell, gastroesophageal reflux disease, like Sherbini said, is the most common disease on the planet Earth, maybe. So eating habits and lifestyle is the paramount role in the management. It is, okay, I know. Okay, it is highly recommended to lose weight, elevate the head, sleep on the left side, and stop the triggers and bad habits. Algorithmic fashion of the management according to the situation of the patient. PPI and PCAPs are a good trial for response in the diagnostic approach. And thank you very much. This lecture is present in more details on my YouTube channel. Please feel free to visit it, subscribe to it, and do whatever you want to like. And thank you very much.